Welcome to this episode of the Authentic Physician Show. I'm your host, Dr. Amy Loden Tiffany, and we are going to continue having honest conversations today about medicine, identity, and health transitions that women aren't necessarily prepared for. If you're a woman juggling work, caregiving, your full time job that you're paid for, and your full time job that you're not paid for, or anything in between, a body that doesn't respond the way it used to, you are in the right place. Our conversation isn't about perfection, it's about truth. And today I have with me Dr. Roshni Patel. Did I say it right yet, or did I get it wrong?
Yes, it's
Okay,
perfect.
excellent. I love it. And she was telling me before we started that her name means light, which is just really a beautiful expression. So glad you're here. Thank you for
Thank you.
being here. I love to get your opinion right off the bat. You're a medical doctor, you're trained in your specialties. I mean, just incredible credentials. But who are you when you don't have your credentials hat on? Who are you as a
Yeah, great
person?
question. The first thing that comes to mind is, and because this is what I have to juggle with my professional life, is I'm a mom. I have two young kids, and I've had to make some career pivots and professional adjustments, I guess you could say, um, as a result of that. And I think ultimately it will be for the better, once I get there. But I love cooking. I enjoy eating and cooking,
Yes.
travel. And now that my kids are a little bit bigger, we, are exploring like how we can travel and experience new places and cultures to learn as humans of on this earth and
Yes.
to spend more time together, meaningful
Mm,
time together.
beautiful. As you did have to make some pivots to create
Hmm.
the life you're living now, and when you get it figured out, you're going to teach the rest of us how to do
Yeah.
this, okay? But I love that you were so honest to say, like, I haven't got it figured out yet, right? You're still
Right.
working on that, and as soon as you get there, I bet it'll change again. At least that's my life experience.
Absolutely.
Is
I
I
think so.
almost have it, and then it changes. I'm curious. What was the driver or the catalyst that made you realize the traditional system isn't working? Many of our audience are not within medicine and they
Mhm.
may feel similar catalysts, but not necessarily have the ability or the option to respond in the same way. So I'm just curious, what was it that drove you to make that decision? And then having made it, what are
Mhm.
some of the things, opportunities, the challenges that you have faced in the life you've created?
Sure. So I think the one of the biggest catalysts was, and this is not unique to having a career in medicine, was the company I worked for essentially closed. And I was distraught, devastated, frustrated, everything, because I finally found a place that I enjoyed working every day. And I liked my colleagues and I liked my office and I had a chance to eat lunch. And a lunch break is so nice when you haven't had one for, for
Right.
years.
Yes.
Um, and when that, company closed, I kind of had a moment where I'm like, I can take the reins and drive my career, rather than, kind of being constricted or confined into this, I don't know what you want to call it, like a maze or a labyrinth that some other, you know, external system or party has set up for me. And I was really
Right.
like, you know what? I can figure this out. I'm going to figure this out. I'm not going to be dependent or reliant, um, on employed positions only. And then it's really the biggest challenge was like believing in myself. And it's still a challenge, There are days where I, double down on my efforts, and there are days where like, oh my God, have I made a horrible decision?
Yes.
More the former than the latter. I guess you don't real some of us don't realize when you're working, for a system or a corporation, how much is kind of done for you. And when we're kind of having this moment of I need to reclaim my autonomy, it means a whole lot more than that. And freedom doesn't mean free from responsibility. I am free to, make the choices I want, to help support my life and my family, but it doesn't mean it's going to be easy or seamless or I get it right the first time.
Right.
Yeah.
And so you've probably had to do a whole lot of learning to walk in this role. What I mean
Hmm.
that as babies we fall down, we walk, we get up, we try again, right? And I imagine that you've experienced some of that. So that our audience has a little bit more on your background. Tell us your basic training and what you did switching to where you are now.
Sure. So I was kind of an unconventional like college student. I wasn't sure if I wanted to pursue medicine. I kind of liked the idea of being in a space that was related to healthcare, but I knew I always wanted to help women. And I actually didn't do the whole, major in a science and go to med school and follow that, prefabricated path, which kind of makes sense for who I am. So I worked in different areas. I was an executive assistant, was had a little small role in marketing. And then I decided, okay, I'm gonna really give med school a try. And come from a healthcare family, so they were relieved in some ways. Um, and then, I did a post back to get the coursework that you need to apply for medical school. Took the MCAT while I was working part time. Um, Went to medical school. Everyone said, "Don't become an OB-GYN," and I was like, yeah, I like it, so I'm gonna do what I like. I mean,
Yes.
it's hard work. This is hard work, what we decide to do. You have to I really do think you have to love what you do. So
Yes.
I did it. I completed my OB-GYN residency training in New Jersey. And after that, I had a slew of sort of corporate type jobs, like working for, one system and then the next and the next. And it was kind of the same. It ended up being the same flavor of medicine everywhere I went until the last place I went, which was had more of a startup entrepreneurial background. Ultimately ended up closing anyway, but that was the place that kind of sparked me to think outside the box. And what was happening, concurrently in my life was the women who I got to deliver their children, they were aging with me. And I turned 40 last year, and some patients are older, some are younger, but this idea of like, well, what's going on with our health after we're done with that phase of our life, if that's something we
Hmm.
choose, right? But we're not quite, menopausal or postmenopausal yet. Like, how do we also help women in that in between kind of place? I don't even like calling it in
Yes.
between because it's its own chapter. We call it in between. I don't know, because it's kind of a patriarchal bookcasing of
Yes.
that's a whole other topic. Um,
Right.
but I pursued certification through the Menopause Society to become a Menopause Society certified provider so that I could have the knowledge base and the resources to provide the best type of care.
Yes.
Um, and that's kind of, brings us up to speed, I guess, to now.
Yeah. No,
Yeah.
I think that's a really helpful perspective for our audience because the assumption that I hear from most patients, I too am a certified menopause provider, and I think the assumption is that OB-GYNs are the women's health doctors and therefore they should know all this.
Hmm.
And as an internal medicine doctor, we certainly do not get a lot of women's health training to the
Right.
degree the OB-GYNs do, but there's gaps in both silos and
Absolutely.
trying to be it all to women without extra training or support. I don't think our listeners realize it's probably not realistic to expect from their physicians. So I'm curious if you could maybe speak into that a little bit specifically, because there's a lot of OB-GYNs who refuse to do anything with menopause medicine, as are
Right.
most other doctors. So I'm not picking on the OB-GYNs, but I think it's startling to a lot of patients that their OB-GYN wouldn't talk to them about it necessarily, or they feel blown off. And I'm curious what your thoughts on all that are.
Yeah, I think part of it starts with like how our education and training systems are designed. Um, not to say that we are not equipped with high level competencies,
Right.
obstetrics, I can remember like older attendings talking about how, obstetrics has become more surgical rather than, hands-on. Um,
Yes.
and residency for me was a lot of, and I trained in a very like an inner city environment. So high acuity, high pathology. It was really just like, can we save these people and get them out the door? Um,
Correct.
and I think I can't say that all residency programs are like that, but the nuance really comes in, I think, in the outpatient world where you have the would like to have the time to sit and talk with
Yes.
patients, understand what's going on with them, with their lives,
Mhm.
how you can support them, what's feasible with how they live.
Yes. Mhm.
I'm going a little off track, but in training, we didn't, I barely had education around menopause care. And perimenopause was even less than menopause. And I think
Yes.
there's some relationship, but they're still different.
Right.
Um, and patients, like you said, they have that assumption that, oh, you're an OB-GYN, you take care of anything woman.
Right.
And then
Yes.
how it translates in real life is, a patient will come see me in her 40s. And I'm like, oh, but also, did you have a colonoscopy? And do you have a
Right.
primary care doctor? And I try
Right.
to fill that gap
Yes.
in the 15 minutes that they used to give me. Um, and I very quickly realized, like, I am not doing a good job here. It's not
Correct.
fair to the patient.
Right.
Um, yeah.
Or you. It's not fair to
Yeah.
you either because you're not able to provide the education and the healing that you're equipped to provide.
Hmm.
And
Yeah. I
so you
think,
recognize
yeah.
this and sorry, I didn't mean to interrupt you. Go ahead.
No, what I was going to say is just that I think how we train our future doctors and we're lifelong learners, right? Like, what type of CME is actually going to move the needle here for us, and
Yes.
what are we trying to do in terms of our practice?
Mhm. And so you became Menopause Society certified. And now tell us about your current work and how that plays in for you.
Sure. So I decided to take a step out of the insurance world and launch a direct care practice, and it's has to be a micro practice because it's just me right now.
Mhm.
And I do
Yes.
everything from scheduling to seeing patients and answering requests and questions and things like that. So you also learn a lot about what works and what doesn't, and the nuts and bolts of operating, a
Yes.
business. What's great is, the Menopause Society also kind of gets you into this network of other, care, physicians, nurse practitioners, PAs, and you can, have this communication with them, dialogue with them. You have access to their resources. I went to the conference last fall. Didn't go the year before that. But it's just nice knowing that there is a way to keep the conversation going, share ideas, how we troubleshoot, an issue with one patient, how it could help somebody else. The interphysician support has really been the most um, a little bit surprising, but also very reassuring. Like, it's really great
Yes.
to meet at conferences and talk to people like, I do this in my practice and this is how it, works for me where I live in my state. Um, so it's really nice being a part of that community.
Yeah, absolutely. So with direct, I guess gynecology, is that how
Hmm.
you're positioning it? Okay. So with direct care, our listeners may not all be familiar with that model. You mentioned it's not insurance and that it's a micro practice. So to me, that means you have a very small number of people and you spend more time with them. Is that how you would define it?
Yeah, that's how it translates. So I'm based in New Jersey, and how I kind of explain is the direct care means the care goes directly from me to the patient, and we work together discussing, we do a deep dive in terms of the medical history, problems, what the patient is actually looking for, and what her goals are. Um,
Yes.
when I was working in kind of the insurance world, it was very much like, oh, you're here for your annual, like, boom, boom, boom. Here's your mammogram, like,
Correct.
go, on to the
Right.
next one. And you don't
Conveyor belt.
have that. You don't have that time and space to really address what's going on for the patient. Maybe she can't have a mammogram because of fear of, I don't know, something that had happened to her in her past, or she's not sure why she's having that done. What are other modalities to talk about breast cancer risk? Are we doing a comprehensive breast cancer risk assessment through her family history and her personal history? Like, are we really appropriately, taking care of the patient that's in front of us? So direct care allows me to do that because it's just me and the patient. I don't have to tick any boxes or write my chart in a certain way and bill it or code it to make the insurance side happy.
Yes.
I am there
Right.
to really care for the patient.
Yes. And I imagine in your experience that this has liberated you and perhaps even your patient. Do you think that there are aspects of women's care? Let's just pick perimenopause. Do you think in that season specifically, there are things women are fundamentally misunderstanding about their bodies?
I'm not sure about misunderstanding. I think there's a lot of misinformation. There's a lack
Yes.
of information, and
Mhm.
then so that void lends itself for anything and everything to fill it. And
Right.
social media is a powerhouse. It's a blessing and a curse.
Yes.
And patients will sometimes utilize social media to get maybe the answers that they're not getting from their
Mhm.
their doctors and nurses who they
Right.
want to be getting it from. And then on the flip side, I actually really like it when patients come to me and they say, "Oh, well, I saw this on whatever, Facebook." And now I have the time to kind of break down why that could be applicable or not, or why it works for
Mhm.
someone down the street, but not the patient in front of me.
Yeah.
Um, it's really that education piece that I think a lot of women in perimenopause or those who are experiencing perimenopause don't have access to. And hopefully I get to do that, one patient at a time.
Right. Right. That's a good point, and I think you ask any physician of any specialty, and they're gonna be like, "Oh, social media, all the things, all the bad." But I'm gonna flip the table for a second, and I'm
Mhm.
curious if putting on my rebellious hat, if you will, are there things that we are saying in conventional medicine and Western medicine that, traditional OB-GYN, internal medicine, it doesn't matter what specialty, we're giving women advice that's potentially harmful?
You know, I think there's one example that comes to mind: bone density testing. And this is
Yes.
where I've actually changed how I practice. By the books, ACOG, ACOG is one of those big organizations that I rely on to help make
Right.
sure I'm
Yes.
navigating care appropriately.
Yes.
Says you start screening at 65. And
Right.
patients will ask, well, I had this history or such and such happened in my family. Like,
Yes.
can I make sure I'm okay? And, like, that's a
Right.
great question, and then I get to
Mm.
talk to them about it. Well, does it make sense for you? And, like,
Right.
even in how I practice, sometimes I will offer it a slightly earlier, because then a patient has the opportunity to make the interventions that are going to hopefully prevent her from A, having osteoporosis, and then
Right.
B, having an osteoporotic fracture, which is just like nobody
Right.
wants that, bad for
No.
everybody.
Right.
And so I don't think that advice is being given out, like that age of 65 is being given out with the intention to harm
Right.
a 55-year-old, but that's
Right.
probably there was a large pool of data, and that's where they found where it made a difference on a
Yes.
population level. But I'm not treating,
Correct.
populations. I have to treat the woman
Right.
in front of me.
Absolutely. And inherently, I think most physicians that we would talk to would agree with the statement of yes, we have to look at the population as well as the person. But it's really confusing to navigate some of the data, right? And we can find it in our research studies, both for pro or cons. And patients can find a lot of that information too. It's not that
Mhm.
it's unique to us. And it does cause a lot of confusion, even if it's not misinformation. Um, I think the bone density is a fantastic example. The other one that comes to mind for me, thinking through this is, is estrogen as harmful as we've been sold to believe it is? The Women's Health Initiative, great job getting a lot of people in it, but that study's not going to be repeated. So how do we parse
Right.
data from it that's meaningful? And how do we not harm women who we know at least deserve to have the conversation about it. As an internal medicine doc, like my thing that I am always looking for is what are your risk factors for heart disease, right? Heart disease, heart disease, heart disease is our
Right.
song and dance. And I don't think a lot of women realize that if they have significant hot flashes, what we call vasomotor symptoms in medicine, hot flashes, night sweats, that's a risk factor for heart disease. And if they just knew that, I think it gives room to then have the opportunity to say, what do I do with this information? Maybe I do or don't want hormones, but don't you at least deserve to know what your options are and make that informed
Absolutely.
decision? And that's what I love about what you're doing with the micro practice. I would say my practice is very similar. We have a small number of patients. I don't actually know that anyone has studied the difference between like the DPC versus the micro practice versus the
Yeah.
concierge and can make a clear definition everywhere. So for our listeners, you might want to do some investigating in your area. But I find that being able to spend the time with people and give them their options, and then even if they disagree with me, I
Right.
know I've done my due diligence to give them the information. That's a much more rewarding place to be when I'm wearing my physician hat than when I had 3,000 patients and was trying to go
Absolutely.
through the rat race of just churn and burn. And people didn't like that. I didn't like that. And yet, as a society, that's where we're at. So
Yeah, it's unfortunate.
it is unfortunate. And I wonder what it's going to take to make it stop. There's certainly legislative processes that are in the media right now, and maybe they'll work. But the more I look at this, the more I think it's got to come from patients. It has to be a complete rejection and it has to be joined by the physicians. And I'm going to loosely say physicians, but I acknowledge our colleagues in all the different areas would join us, right? Because at the end of the day, the patient and the physician and all their team is really wanting the same thing, which is the patient to have better outcomes. Um, I think insurance, this is my opinion, so disagree with me here if you wish, okay? But I think insurance is misaligned in how they provide any benefit. Their goal is on paper patient care, but in reality, it's their shareholders and it's
Yeah,
the people who will benefit from the business side of it because it is a business.
it is.
And I think if patients understood the reason they're being told no, is because the goal is to maximize shareholder profit. And if we were actually just honest about that, it would make a big difference. But I don't think anyone at any insurance company is going to tell you that, oh yeah, my incentive is this, right? And ironically, I don't think they're actually I really don't believe most of them are malignant in what they're doing. I think they're trying to do a good job for the company they work for, but the incentives are misaligned. And so
Absolutely.
don't hear me saying that I hate insurance employees. That's not what I'm saying. I'm just questioning how long are we going to let this model go? And most people now are paying more out of pocket and they're still paying their premium that
Right.
they can save money to just put that money toward, in your example, a direct patient model. That's my rant. I'm curious if there's places you disagree or you'd want to go further on. I try very hard
Well,
not to get too preachy on this.
no, I think it's important, and I think, related to that, you I don't think American physicians, and I'm saying physicians broadly, have the luxury of staying apolitical any longer.
Agree.
We're in crisis, you know. And I kind of smiled before because I explained this. I explain it to patients this way too. I'm like, the incentive of the insurance company is to make a profit. I
Yes.
used to have I worked for a practice that was owned by private equity, and I used to, be private equity is killing everything and everybody. But I'm like, oh, actually, they're just doing their job, which is take this company, strip it to parts, sell the dust under the table for a profit and ship it off and move on to the next one. Like that's
Yes.
literally their MO. And then when you pair that with our profession, which is the goal is to learn as much as we can about the human body and our specialized or, within our specialty, and then provide good care and counseling and
Yes.
interventions and the things, they don't line up.
No,
And
they don't.
we've let it get kind of out of hand.
Hmm.
Um, and I
We
think
being
patients,
physicians.
I think physicians have kind of given away a lot of the power.
Yes.
Um, Actually, I was talking to a cardiologist today, and she said, "I don't think these admins. I should be working for the administrators. They should be working with me." Like,
Yes.
you know,
Yes.
um, and I think yes, it has to come from physicians who are willing to step outside and listen. That's also a luxury. Like I'm taking a risk
Correct.
here. My family had to be
Correct.
on board with it. Not everyone can leave right away. So
Right.
it has to come from physicians and patients. And it can start with a little no. It doesn't have to be this
Yes.
big dramatic statement.
Right.
I think the
Yes.
little victories will add up.
I think you're right. Just like in our habits, the little habits stack
Hmm.
up.
Absolutely.
And it's good to see other people in different specialties. And I had this conversation several years ago with a group of women physicians, and I was surprised by the hostility to what I was saying because most of them were like, if I wanted to run a business, I would be a business person, right? Or not all of us can not work at the hospital and so forth. And there's some truth to everybody's opinion and belief. And so I'm not going to dismiss those. But I was surprised at how many had already just bought into the mindset of, I don't have another choice. and I reject that, and I encourage my patients to reject that. You have choices. And part of my hope in even having these conversations is that people see the behind the curtain of what
Mhm.
medicine and healthcare is. I think it's always my nurse practitioners love to harass me a little bit because they get Nurses Month and then there's Doctor's Day, and
Yep.
they'll pull up these quotes and they're like, "The public trusts nurses more than doctors," and it's fun. Like we're winning it in a fun way, but when you look at those facts, it's a little bit startling because why wouldn't they be at least the same? And I don't think COVID caused people to not trust doctors. I think that mistrust was already there, but I
Agree.
think COVID significantly amplified or unmasked what was there. And now we have people, whether you love or hate what the government's doing, it is definitely different than what it was. And so that leaves a lot of opportunity for misinformation and for people to take advantage of the situation. And as I'm watching this from an outside the system view, curious your thoughts on this. It seems like this is not just the moment we need to step up and stand in, but this is the moment we need to be articulating more clearly to our patients of why they need to do the same thing.
Definitely agree, and I think sometimes that, kind of hostility or that rejection of, "I can't run a business," you know, and I have the luxury of coming from a healthcare family.
Yes,
That's what doctors used to do. They used to
correct.
run their own practices, and maybe they had,
Yes.
like, a manager or a biller or
Hmm.
something, um, and I'm talking, like, 50 years ago how medicine was,
Right. Right.
um, and that the flipping of that has really gotten us to where we are today.
Yes.
Um, and like to your point, what's happening in our some of our most trusted organizations
Right.
leaves us, scratching our heads and laughing sometimes at like, is this real? I
Yeah.
joke, I'm
It
like, is
feels
this
like a
really
movie.
happening? Is this
Right.
my real reality right now? Or
Yes.
is this a
Yes.
bad dream? So
Right.
yeah, and that's, I say sometimes to my other OB-GYN colleagues who still work in the insurance world, I'm like, this is my little rebellion of going outside and not
Right.
being, beholden as an employed
Yes.
physician, but really, developing my craft as a physician. Cause that also
Right.
wasn't happening when I was working for these
Yes.
big systems. They don't want
Right.
you to, you know, they want you to do enough CME so you can stay on staff at the hospital. They don't want you to
Right.
actually grow
Yeah. You have to fit their mold.
professionally. Yeah. And I'm like, well, I'm doing different things. I don't want to see as many OBs. I want to see like more complex GY. And it's just no. Like I
Mhm.
heard no's. And
Yeah.
so yeah, I have many, many points to share. But yes, I think it really needs to start with the doctors, and then we can help show our patients what's really going on, and they can also
Yes.
participate in their way in really changing
Right.
the system.
Absolutely. I am shocked often when I hear this come up, this idea that doctors have so much control of the system. Because in the system, we know we don't have any control. And it's startling when we hear, I'm just going to say the news in general, right? Talk
Mhm.
about how expensive healthcare is. But when you really break that down and you look over the past several decades, it's not because of doctors and their salaries, it's all the administrative bloat that comes with it. And I do not think the public understands that. That one, we don't have the power, and number two, we're not the cause of what they're
Right.
experiencing, either in their insurance plan rejecting things, not paying for medicines. We had a patient last week who went to the lab. She's gone to the same lab for 5 years. It's a hospital-based lab, and insurance hasn't significantly. It's not a different carrier or policy,
Mhm.
but January 1st, the benefits changed, and that wasn't articulated to her. And I don't think anyone calls their insurance on
No.
January 1st or the renewal date and says, "Hey, what are my new benefits or what do I
Right.
not have from
What
last
should I
year?"
look
Right?
out
Who does
for?
that, right? Exactly.
Nobody.
So she goes to this lab, gets routine labs. We're not even talking about fancy labs, and gets a bill for $1,200. She's mad at us because we didn't tell her that she was out of network with the lab, and I was like, "I had no idea. I don't know who your
Right.
in-network lab is, right?" People think we would. The lab doesn't know. They just billed her insurance. And
Yeah.
so I understand the anger. I would be shocked at that bill too. And it's very helpless feeling to know that this is not just one isolated event. This is happening across the
all the
country,
time.
right? All the time. And the only one who's getting the benefit is the insurance's bank account, right? It's not the patient. And in some cases, I think it's harmful, at least emotionally, mentally, psychologically harmful, if not other ways. Because not everyone can, even if you have the luxury of paying out of pocket, you don't have the necessarily luxury of that kind of dispensable cash. And
Absolutely.
so that's a real scary thing to think that this is going to keep happening and become more frequent. Um, I mean, if my doctor told me you need to call your insurance to find out if this is covered, I would laugh at them. Are you kidding me? Like, I'd rather take the gamble and not call them because I hate
Yeah,
calling them as a patient. So, um, as a physician patient, I have to imagine our non physician patients are also very upset and frustrated by it and feel helpless.
absolutely. Labs and medication that kind of go hand in hand. And I only learned about the level of bloat really when I created my own practice and I kind of toyed between, do I want to do client billing, which is where I would
Yes,
pay, LabCorp or whatever third
right,
party, and all my CBCs are $3, $5, like
right,
pick a number,
right. Yep.
versus third party billing, which is what I'm actually doing because patients are like, oh, I want to go through my insurance. So I was like, okay,
Mhm.
I,
Right. Yeah, you're
and
gonna
they're,
pay more to go through your
you're going to pay
insurance.
more because patients don't even know that a lab will contract with Cigna. I'm just picking a name out of the sky, and they have an arrangement. And like, I also like it boggles my mind. Like, I'm not a business person. I didn't go to business school. I don't have an MBA. Like, how is that not a conflict of interest? Like, how is that,
Right,
we can't accept a cookie from
right.
Pfizer, but like,
Yes. Yeah,
but all this can happen. So, I mean, I'm being very, I don't know, abrupt in how I phrase it.
I
That's
think you're
my East
good.
Coast coming out here.
I love it. Hey,
But
I trained
that's
in New York City. It's okay. I'm with
yeah,
you. I'm
okay.
tracking.
All right. So, and my husband is a business person, right? So I come to
Huh?
him and I tell him these things, and he's like, "That's how it is. Like, this is the, it makes more money for these companies." And the patients have no idea. They think, "Oh, the copay is going in the doctor's pocket." No, the system of co-insurance was designed so that they're already acknowledging, like, you're not gonna get reimbursed all the way, so here's a little bit to hold
Right.
you over. It's
Yes.
bonkers. It's already
Yes.
designed to accommodate the known deficit, like,
Correct.
yeah.
I think, if people understood all the stuff behind the curtains, it would cause them to rebel a lot faster.
Yeah. Yeah.
But it's so dadgum complex. And right, even if you try to call and find out, let's say you were that really assertive individual who does their due diligence, you're going to get potentially passed around multiple times. You're going to be told you're being recorded. And it's like,
Mhm.
come on. Can you just tell me straight up? You can't find it easily on the website of these
They don't want
companies.
to. Yeah.
They don't want to. It's by design. And if you do want to look something up, you have to have a portal with 50 passwords first. And, it's just unnecessary obstacles. And I love that you're rebelling against the system. I'm joining you in that rebellion. And more physicians, I think, are because it's so obvious to those of us. It's like what's the Matrix thing, the red pill, where
Right.
your eyes are open and then you can't unsee it, right?
See, yeah.
Right. Like now that I see it everywhere. So before I get us on yet another sermon on this, let me come back to your specialty for a second,
Sure.
because I think this plays in a little bit. Are there areas of women's health that you refuse to compromise on that insurance is really in your way on? We talked a little bit about bone densities, for example, but I wonder if there's
Yeah.
other places that this shows up.
Yeah, one of the more nuanced places I would say is, like, in-office procedures, things like, IUD placement, anything actually related to pain control, that's what I'll say, pain management,
Okay.
and,
Yes.
there's 2 big problems, like, in training, I am embarrassed to say this, but it's the reality of my training. We were kind of taught that, "Oh, there's no nerve endings in the cervix. It's not going to hurt." And I'm like, I don't know. That thing looks kind of sharp. Like, are we?
Right.
I don't want that near me. Um,
Right.
and I didn't totally believe them, but I was like, I want to be a good little resident. Get through
Right.
this. And then that carries over in insurance, like in office procedures that I think for a man would, you'd have
Yeah.
anesthesia covered. It's not.
Yeah.
So, and to kind of circumvent that, we talk about pain management. We talk about pain management. We talk about trauma. We talk about, how can I make this experience? We have to do, XYZ in the office. How can I make this easier for you? Whether it's a scheduling thing, a pre-procedure, medication, on-site medication. And sometimes that means paying out of pocket or, you know, paying for it. And I'm very, candid about the options for patients. And some
Yes.
patients elect to have something to help them feel more comfortable during the procedure. And some patients are like, you know what, that's okay. But I think, can I get a note for skipping work? I'm like, absolutely.
Right.
Like, why not?
Right. Yeah. Yeah.
So that's the hill I'm gonna die on. Like, people should be comfortable.
Yeah.
Yeah.
Agree.
I don't
Agree.
think that's
I like
unreasonable.
that. No, not at all. I like that example too. And I'm trying to remember, you can help me here. I recently saw something, another physician advocating. I think the comparison she used was that if a man goes in for a vasectomy, he's going to get anesthesia. But if a woman goes in for an endometrial biopsy, she gets
Nothing.
nothing. Is that accurate or did I make that up?
Think that I've heard that, and from I hate using the line, "From my own experience," but in my
Yeah.
life, I have seen that.
Okay.
Um, yes, I, have someone I know that had went through a vasectomy, days off, like, I don't think it was general, but it was real anesthesia.
Yeah.
Um,
Not
and
an ibuprofen and get back up and go to
correct.
work.
Like, not like,
Yeah.
yeah, and I just think it's so disgusting to say that just take 2 Motrin, you'll be fine. It's so unfair.
Yes. Right. Right. I completely agree.
Yeah.
I cannot believe how fast our time has gone,
Yeah.
and we are quickly approaching the end. What have we not talked about that's important to you that our listeners know and understand, either about medicine or what you do or anything you want to go and share
Yeah.
on?
I think the important thing is to remember we're all human, trying to navigate what's in front of us, and doctors are not perfect, and I think good doctors try to do their best, um, and I think you and I are living proof of that. We stepped outside of the conventional framework to do better and to live better. Um,
Yes.
I'm a better mother when I'm a good doctor and vice versa. They feed into each other.
Yes.
I can't come
Right.
home post call tired and frustrated and angry at my children who have no they don't deserve that. So I saw
Right.
that and I was able to pivot accordingly. So just we need to remember we're human. We have to treat each other as humans. It's a
Yes.
decent thing.
I love that. Thank you for sharing that because I think even if someone's not in medicine today, they probably have those same stressors in their industry. And they're also trying to figure out whether it's their kids, their parents, someone else that they're caregiving for, stepping into different roles of than their main career. It is very much validating that it's okay to be human. And
Absolutely.
you're not, we're not perfect. And when we acknowledge that, it gives each other a lot of grace to start being who we're called to be and created to be. And so thank you for being here. If our listeners want to get a hold of you, you said you're in New Jersey. Are you taking new patients? How do they get a hold of you? What's the best way?
Sure. So I am taking new patients for virtual care and I offer home visits as well. My website is Luminate Gynecology. It hopefully should pop up if you do a quick search. That's the name of my practice. Luminate also refers to light, and my name means light. So I thought, why not?
Well, beautiful. You tied it together. I love it. I love
Yes.
it.
Yes. Yep.
That's fantastic. And of course, we're here in St. Louis. So if we can be of help to you, feel free, our listeners, to reach out. We will put Dr. Patel's information in the show notes so that you can find it there as well. So if you're driving or trying to juggle something right now and didn't catch it, it'll be there. Go back and pick it up there. If something in today's conversation resonated, it's because you're not alone and you're not imagining it. You can find more support and resource next steps, as I said in the show notes. You can reach out to us directly, but most importantly, know that you are valued, know that you are worthy. And if this episode helped you feel seen, please share it with another woman who needs to hear it too. And we'll talk more on the next episode of The Authentic Physician. Bye for now.